can say essentially failure to get across initially, but we can prove at the end we did a great job.
That's the
so it's
main
fine.
objective, right?
Yeah,
Was doing it post to ensure
normalize it. And it was obviously going to be
you're not
wildly
leaving,
abnormal.
residual ischemia.
Hey everyone, Chris Brown here with another video for Murmur. I'm fortunate enough to be joined by our guest today, Christian McNeely. He is an assistant professor of medicine at the Washington University. He's also the director of quality for Barnes-Jewish Cath Labs. And we're really excited to have him here today. He's going to talk a little bit about physiology, which we all know, and he knows way better than us. So Christian, thanks for doing this with us, man. We really appreciate it.
No, thanks for having me. Excited to be on here and talk, and really enjoyed the podcast. So, excited to contribute.
Awesome. Let's go through it.
Yeah. So I think today I mostly just kind of wanted to talk about, physiologic guidance for PCI. I was fortunate enough to be the site director or the site PI for the Define GPS trial. I'm not sure if you know anything about the trial or whatnot, but its aim was really to evaluate physiologic guidance of PCI using co-registration versus standard of care. The background for this trial came off of this trial that was called Define PCI, which found that about 20%, if not more, of patients left the Cath lab with residual ischemia as measured by a pressure wire, and of those, the majority of them actually had ischemia that could be resolved by just a simple balloon dilatation or an additional stent. So that was kind of the background for this trial.
Awesome. I did not know that that number was that high. And that is very concerning.
Yeah, and it was by really good operators, actually. I think it was most of the group in the UK.
Wow. Yeah. I mean, and just as a side note, before you get into Define and show us some stuff here, was that was some sort of retrospective data without mandatory imaging and things like that, or this is like image guided PCI and it just happens to be that even without that 20% have?
Yeah, it was majority of them. It was in UK. Majority of them did not have imaging.
Okay, got it.
But they were good operators at high volume institutions, and it was, they did a blinded pressure wire assessment post intervention.
Oh, okay. All right. Well, let's get to it then. Let's hear about Define.
Yeah. So the Define GPS trial again was a randomized trial evaluating the performance of physiologic guidance of PCI versus standard of care, and this kind of the acronym below. So a lot of words there, but.
That's a lot of words. Thank God I can read.
Objective of the study was really to demonstrate that physiologic guidance of PCI using the co-registration system would be superior to angiography alone. And so there's a bunch of secondary kind of objectives for the study, but that was the primary objective. So the patient population we were studying was really anything besides STEMI and cardiogenic shock. Patients were qualified if they had an ACS and greater than 50% stenosis, or greater than 80% by visual estimation, or if they had moderate disease with physiologic significance by IFR, which is 0.89, or by FFR less than 0.8, or if they had moderate disease with a corresponding stress test in that particular distribution. So the main endpoint of the study was MACE, and this will be reported at 2 years. I think there'll be some data at 1 year. We just finished enrolling for the trial this past May with about 2,100 patients. So kind of anticipated late 2026, 2027 for study results.
Awesome.
And again, we kind of mid 2027, and at WashU, we were the number 4 enrolling site. So we had a pretty robust enrollment. It was nice to be kind of a part of it and whatnot.
Yeah, it's a big trial. I mean, it's important. Like I said earlier, I mean, that's a big deal to have 20% of people have residual physiologic problems or unresolved things when you're not doing what you should do.
Yeah. And I think one of the things I really enjoyed about the trial was just learning a lot. And, would get surprised on both ends sometimes with using the pressure wire. And times you normally wouldn't use it. And I'll kind of show a couple cases that kind of
let's
show a
see.
little bit of that.
So we love to learn what you've learned from this, because this is certainly not our standard, if you will. I mean, we use physiology the way that I think you probably think of it, which is we see intermediate lesions and we do what we need to, whether that's resting or hyperemic physiology, and then I never put that wire back in. And I certainly don't. I do pullbacks, but I don't like actually co-register what I'm doing. So we're excited to sort of see how you do this.
No, for sure. So this is an older lady who presented with a non-ST elevation MI, kind of potpourri, usual risk factors. So right corner had some, just diffuse calcific disease. Nothing that I thought was greater than 50. Circumflex, this real tight lesion in the mid-segment, heavily calcified.
Yeah.
And the LAD also this, kind of long area of moderate disease, not critical.
But got some calcium and definitely doing something.
So this was someone that, I decided to enroll in Define GPS. So, the mechanics of this. So initially I did not need to pressure wire the circumflex, obviously. The LAD I did.
Awesome.
And
so you fix the circ first. And in the trial, is that what you do? You fix the whatever?
Yeah, we'll kind of get there, actually. So my I was going to fix the circ first, and it was balloon uncrossable. So I got a wire down, couldn't get a balloon to cross. So I said, look, we're going to kick this can down the road a little bit. So the pressure wire evaluation on the LAD was 0.78. At this point, that is when you randomize, so to whether or not you do physiologic guidance of PCI or not. So you do a blinded pullback on FFR.
A resting ratio. And you could use either hyperemic or resting in this trial?
Correct. Okay. You could use either.
It's a very positive resting ratio.
Yeah, the times you would use. So for that case, I actually I had to do the pullback on FFR because I didn't know where they were going to be randomized to yet.
Okay.
But because the FFR, you can't localize, like a co-registration. So she was randomized to physiologic guidance. So what does that look like? That means the first step is you set up a co-registration image. So this is what a co-registration image for that patient looks like. So the mechanics of this is that you have the wire down. Under continuous fluoroscopy, you pull the wire back, you stop the recording, you take an angiogram, and the Philips system will automatically co-register where the ischemic units come from. The objective of the study doing PCI is to have, ideally, a post-PCI IFR of close to 1 as possible, but greater than 0.95 was the minimum that we were trying to achieve. So this is our roadmap for the LAD. So for this lady, what we did was we initially fixed the circ first. So I tried to get the pressure wire down, wouldn't go. I wired with a fielder, swapped for a wiggle. Still couldn't get a pressure wire to go at this point, and at that point I said, look, I'm not going to try and get a pressure wire down. So I did kind of your standard guide extension delivered IVL to treat this. And I'll show you the kind of final result here. So that was for the circumflex.
That looks great. And then do you still do do you still randomize that lesion or just the LAD?
No, at this point she's randomized to the Define GPS, the active arm. So then I had to do a Post-PCI IFR, which we measured at 0.99.
Okay, cool. So you can say essentially failure to get across initially. But we can prove at the end we did.
Yeah, and then that's the main objective, right?
Yeah,
was doing it post to
normalize it, and it was obviously going to be
you're not leaving, residual ischemia. So then. At that point in time, we moved on to the LAD. So again, we did our co-registration image, which I showed already. That's kind of the mechanics of it. So put wires down, pretty calcified imaging. Use the same IVL balloon that we, had in the circumflex for, was able to
I like
deliver
it.
that just fine. Did some standard dilatation. After that, I just kind of saved that diagonal. That was the end on the LAD. And again, post-PCI IFR was required. And I'll show you the cover. That was the, 0.97, 0.99. These two dots are just kind of just depend where you put these cursors. So,
And tell us sort of how that co-reg works, because I don't have this. I think a lot of people probably don't have this. So you take an angiogram in a view, and then what do you do?
yeah. And so, and you can actually do this with either IFR, pressure wire, or with IVUS. So the mechanics of it with the pressure wire are that you do a pullback on continuous fluoroscopy, and then you step on cine, take an angiogram, stay on for 2 beats, and it automatically co-registers the ischemic units. Alternatively, if you have a second wire down, you can step on cine and it will co-register on that wire. It just needs something to co-register the vessel shape on.
Okay, and that thing needs to kind of remain in that position then when you do the actual pullback?
Yeah, you can't move the II or the table.
Okay.
So the mechanics are you put the pressure wire down, you check out a spot IFR, you then do a pullback, continuous fluoroscopy, take an angiogram, or just tap on cine if you have a second wire in the same location, and then it will co-register. So kind of like that. And you can do the same thing actually with IVUS and click this little button right here. So you can do an IVUS co-registration to, you can see what that IVUS, that position looks like in that vessel on IVUS, and gives you your length. So it's real nice if you're stenting like a 50 millimeter segment that's longer than your IVUS catheter. You can kind of just drag that, along the length of the vessel, measure your distal, measure your proximal, and then you can just ask for your 2 stents or whatever, and it makes it kind of easy.
Awesome. This is interesting because this IFR is wildly abnormal, and as you mentioned at the beginning, I mean, it is a severe-ish lesion in the LAD, but it's more on the intermediate side than it is like the circ lesion, which is like uncrossable. It interests me, and I don't, maybe there's no data, or maybe of some data, or maybe we'll just speculate together about how calcium really affects this. Now, obviously, that vessel is huge once you IVUSed and made it look perfect, and of course, we know that you made it perfect because the IFR is perfect. But that I do wonder how long segments of calcium or just long I mean, you can talk about long lesions. I guess calcium doesn't have to be part of it, although I think calcium contributes to turbulence in some way. How that sort of changes physiologically what these things look like. Because, when I first started, when I started our program, they were used to not doing so much physiology and other stuff. And we would do a lot of physiology of lesions. They'd be like, oh, that's just intermediate. Why would we don't need to fix that, right? And it's like, then you do it and you're like, no, that's wildly positive.
Mm-hmm.
And our staff really kind of had I don't want to say an awakening, but they learned a lot, I think, and I learned with them, I suppose. But it's like, these long lesions they're really interesting.
Yeah, no, I mean, I think to that point, I'm not aware of calcium as a modifier of how it affects the performance of pressure wire, but I think to your point, it affects our performance of judging the angiogram. If there's severe calcium, I think you probably get a lot more variation in what operators call the severity of the stenosis. And so that's where I think, pressure wire evaluation really just gives us an objective number to go by.
Yeah, I mean, I guess maybe that's the key, right? Is it takes the subjectivity out of it, which is what you want if you're a patient.
Yeah, and I think frequently also, for the LADs, kind of classically, we underestimate by, these long LAD lesions by angiographic severity, and then you put a pressure wire in. And then on the corollary, right short focal right coronaries are kind of classically overestimated by angiography, and then you do pressure wire and it's okay.
Yeah, no, you're right about that. I find that in circumflexes that are non-dominant, I'll put the wire in thinking that something looks like it's closer to 70%, and it's like, the physiology is like 0.98 or something.
Mm-hmm.
And that kind of is what it is. But I like this. I mean, this is how do you use imaging in these cases? I mean, I suppose it's an adjunct in the sense that, obviously you imaged and you chose your sizes for your IVL and your stent and everything, and then your landing zones. And do you think that you need the post-physiology part if you have the imaging part, or it's too hard to say, or what do you think about that?
I think it depends. I do think there's some times where it's additive in the cases of I think particularly these long lesions that we stent often in the LAD. Your typical kind of cut points of 90% distal reference, used by Ultimate, that may not be adequate really if you think about a proximal reference vessel, 4 millimeters, and a distal of 2.5. So I think in those settings it can be additive. But I would say in general, it's not really, I would say, necessarily additive to do both. I think part of me wonders, with this particular, the post PCI co-registration is that will it allow places to kind of defer, your post PCI imaging, or defer doing imaging if you have a pressure wire evaluation that's 1.0 post.
Yeah. Well, I mean, I think what you said is really relevant, though. In an LAD where people, we frequently see this, perhaps the under like the proximal LAD here, huge diagonal comes off, big step up in size. If you do what you said, right, 80% of distal reference, media to media or whatever, and you put that in the proximal portion, that's just going to end up being wrong, right?
Mm-hmm.
And that may not get you this perfect IFR, but you may not know that if you don't IFR. And, people rightfully so are concerned or trying to be thoughtful about vessel sizing because they don't want to have a perforation or whatever. And of course, I think I'm perhaps on the very aggressive end of how we size our stents, just because we really think we want the most that we can get out of them. And we modify calcium and try and mitigate that perforation risk by using lithotripsy. But, I think this is definitely something where I could see, especially in vessels with a lot of taper, maybe this is something that I need to add into the mix of, well, did we do an adequate job? Because by IVUS, it might look adequate. Or maybe I think that the eccentric expansion is just enough in an area that's heavily calcified or whatever it is, and I already ballooned it to 18. But maybe we really do need to do something else, and the physiology would guide me there. So I'm really interested to see where this trial takes us and sort of what it shows.
And I think practically speaking, too, sometimes it can be helpful. If the IVUS doesn't cross orange side branch evaluation, and you really feel like you need to get some additional objective data before you're done, I think it can be a nice tool there.
Yeah, I think that's really good.
And I've got one other case if you want to see it. Kind of.
Let's do it.
So this is again kind of another non-STEMI. Kind of a short focal lesion, tight lesion in that PDA. And then
focal circ.
Yeah, it's focal kind of circ lesion, and LAD just kind of mild stuff. But the circ. So I'll show you the IFR on the circ. Any guesses?
I mean, it's very focal, but it's very tight. It's non-dominant, but I mean, it's tight enough. I mean, if you can get an IFR wire past it.
Yeah, I mean, I wouldn't normally IFR'd it. I just had to for the study.
Right.
For these sort of cases, I put a safety wire on first. But here was it.
It's very abnormal.
Yeah, and then this was the pullback. So essentially 50 dots were right at the that stenosis. So it was just a standard kind of balloon stent post dilate. And the other kind of interesting. There's this osteal mild stuff.
An osteal lesion that I would have normally, that would always give us a little bit of pause, right?
Yeah, but it was completely again, our post PCI IFR here was 1.
Yeah, well, there you go. And the IVUS of the ostium of that circ, is there even any plaque there, or is that just eccentric?
Yeah, there's a little bit. And I'll kind of see if I can roll through it here. So there's a stent. There's a proximal edge, and then come on.
These are manual pullback. This is an eagle eye.
Yeah, this is a manual. I had to use the eagle eye.
And to co-register with an IVUS, you need the
So
Refin.
you
Oh,
got
there
a
is a
little
little
plaque
plaque
there,
there.
you see.
Yeah, there is a little plaque there, but not physiologically contributing.
Yeah, I mean,
Interesting.
if you were to just eyeball your MLA there, that's, probably 4 to 5.
Yeah,
So
2x2 or whatever.
yeah, yeah, exactly.
Yeah, no, I think that's very interesting. And that adds, again, this added value, right? You didn't have to put an osteal stent. By
Exactly.
imaging, you might have thought, oh, well, that's a 50%, 60% residual stenosis. Do I need a proximal stent? It's like, well, the
Yeah,
physiologist says that everything's fine, so you're fine.
yeah. And now if I had done a post-PCI IFR there and I had 6 ischemic units right at that osteal circ, technically I would have needed to treat it
Okay.
by the study, or at least been strongly encouraged to.
Yeah, and so meaning like a residual IFR of 0.94 or less. Is that right?
And say those 5 dots were right at the ostium, and I would have been encouraged to treat it. So then it went to the right, and I actually angiographically called this 80%.
I mean, it's pretty. It looks tight. I mean, yeah, it's a focal tight lesion.
Yeah. So we put our
views.
pressure wire down, do co-registration, all this sort of stuff, and I get 0.95.
Oh, there you go. I would have treated
0.95.
that without even thinking about it.
Yeah, and and I even did an FFR. It was completely, not even close. So even, by this, although it was angiographically greater than what I called, again, 80%,
Yeah.
I, left it for medical therapy.
No, yeah. I mean, that's physiologically negative. It's just, I guess the areas that it's
I think,
subtending.
it's a small vessel, limited runoff. I think if you had that same stenosis in this PL, it's a different story.
Yeah, no, it's really interesting, and it adds a lot of it adds a lot of thought to what we do, right? I mean, I see that normally, and I just don't even think about doing physiology of it. But maybe there are lesions that we need to defer, and lesions that we aren't treating that we shouldn't be, and we need to be a lot more aggressive about both physiology and imaging, frankly.
Yeah, no, I think that's well said.
That's awesome. Well, thank you for doing this. We're really excited to see the results of your guys' trial. Obviously, we sort of will greatly anticipate. You said there might be 1 year data, so maybe we'll see some data at ACC or TCT in 2026.
I'm thinking 20
some things out.
TCT maybe. So.
Awesome, fantastic. Well, thank you again for doing this. We really appreciate it. I learned a lot. I'm going to go now ponder whether I should be treating every PDA that I see that's that tight. And you're just adding more steps to my cases, so my lab staff will hate you. But that's okay, because it's what's good for the patients. So, thanks, man. Appreciate it.
Yeah, take care, Chris. Thanks.